Okay, we are going to continue on with the basic science oral presentations. I want to introduce our two moderators for this session, Dr. Vavaria Kirchner from Transplant Surgery and Dr. Dan DeLito from General Surgery, Surgical Oncology. Thank you for moderating the session, and we'll go ahead and get started.
So thank you. I'm James Harden from the Transplant Immunology Lab with Dr. Sherry Krams, and my project is broadly on characterizing the immune response in transplantation. So in general, the immune response to transplantation involves several different cell types, all involved in recognizing donor antigen and mounting a highly coordinated immune response that can result in acute rejection, as shown in this schematic. However, much of what we know about this immune response is in the context of solid organ rejection in liver, heart, and kidney, which are all single tissue types. And what my lab is interested in is vascularized composite allotransplantation, or VCA for short. And this is a transplant that involves several different tissue types, skin, muscle, bone marrow, et cetera. And what makes this VCA unique and also complicated is that the skin alone can elicit a powerful immune response. The bone marrow can provide inflammatory and regulatory cell types. And you can imagine also all of these different tissue types serve as own reservoir of donor antigen that the immune system can respond to. So one of the key questions for our lab is, how do composite tissue types impact alloimmunity? So to answer this question, I use a mouse model of VCA, and this was developed in our lab by C. Wong, our microsurgeon. And what we do is use genetically different MHC mismatched transplant for our allogeneic model and an isograft for our syngeneic model. And in this VCA, we take the donor hind limb and engraft it to the ventral region of our recipient mice via the carotid artery and the external jugular vein. And then this graft is then repositioned dorsally so that it sticks up upwards and is not in the way of normal mouse behavior like feeding and drinking. And so, as we can see from this histology here, in the skin at allo day 3, there is moderate inflammation that then progresses to severe by day 5. And this is seen by these small, dark, circular mononuclear cells that's infiltrating the skin. We don't see that inflammation in the syngeneic, and instead of day 5, we actually get this granulation tissue here that's indicative of wound healing. And similarly, in our muscle, we see sparse inflammation at day 3 that progresses to severe by day 5. And so altogether, this gives us a window that allows us to capture the events that lead to rejection. And so I then collect samples at days 1, 3, and 5 post-transplant, and I isolate the cells from these samples and perform high-dimensional cytometry analysis, where I measure the protein expression of more than 40 different markers. And this measurement essentially gives us the phenotype, function, and activation state of these cells post-transplantation. Now, with these 40 different parameters, we need a way to visualize this data. And so I use UMAP. And UMAP is essentially a tool whereby the cells that are most similar in protein composition will group most closely together, and the cells that are most distinct will be further apart. And so that's exactly what we do. I plot my data onto this UMAP, where we get a global overview of the immune cells that make up the sort of overall immune response. And so you can see each single dot represents a single cell on this map. And each cell is then color-coded by the cell population that it belongs to. Now here I'm showing you just general aggregate data of my transplant samples. This aggregate data can then be partitioned by condition, so whether it's syngeneic or allogeneic. And so you can see here at day 3, there's pretty good similarity between the two conditions, between the spatial distribution of the cells. But when we get to day 5, some interesting things happen. And so there's multiple areas of this UMAP that show disparate spatial distribution of cells. And what this tells us is that there's multiple cells responding to, multiple clusters of cells responding to the VCA. I can break this down for you further, where we can appreciate the moderate differences in the T cell compartment and the NK cell compartment, and then the rather drastic differences that we see in our myeloid compartment. And this is altogether showing us that there's a unique phenotypic signature of transplant rejection that is evident and identifiable by day 5 post-transplant. Now, most transplant studies tend to focus on T cells, and T cells are absolutely important in the context of acute rejection. But what I'm showing you here is a pretty dramatic phenotype in our myeloid cells, and less is known about sort of their role in VCA. So we wanted to explore this further. Now, the myeloid compartment is extensive. And so I designed these studies to be able to capture several different myeloid subsets, including several dendritic cell populations, including multiple monocyte populations, and different activated phenotypes of macrophages as well. And in these example UMAPs that I'm showing you here, this is an example of how we can capture all of these different cell types. I'm showing you on the left the sort of dendritic cell compartment, and on the right, the monocytes and the macrophages. And we can appreciate the high granularity that I can achieve in these experiments, and get a decent distribution of various cell types that we can then use as sort of a foundation to explore these cells in our VCA model. That's exactly what I do. And so going back to day 5, where I told you we have the most drastic phenotype of rejection, there's multiple areas of this UMAP where multiple different myeloid subsets are responding to inflammation. And I can break this down for you further. So I was able to identify 2 types of monocytes, classical and non-classical, that were both in higher proportion in the allogeneic transplant compared to the syngeneic. And the classical monocytes in particular are important. They're also known as inflammatory monocytes. They will sustain inflammation in this setting, and they will participate in renewal of tissue-resident cells such as dendritic cells and macrophages. Now, these macrophages are also interesting. There's a subset of these cells, so the macrophages are here. There's a subset of cells right in this crevice here that are actually transitioned into an activated phenotype. And this activated phenotype corresponds to upregulation of those co-stimulatory receptors, CD86 and MHC2. And this sort of enhances the effector functions of macrophages. And so they can phagocytose more, and also present antigen to the T cells that we know are important in acute rejection. And lastly, the allo day 5 is marked by the presence of these PD-L1 positive neutrophils. And so these cells are interesting because they're typically known to actually suppress T cell responses. And so in this case, it might be a latent effect of inflammation, or pointed to a particular role for these cells in sort of the resolution of the immune response. Now, I told you that there was unique features of this model with both the bone and the skin contributing to sources of donor cells. And so what we want to know is, are any of the cells in our signature coming from the graft? Where are these cells coming from? And so we're able to track donor cells in our model. We use an antibody to MHC1 that's present on all cells, specifically against H2DD, which is only on our donor cells in the allogeneic model. And what I'm showing you here is that there's virtually no donor cells that we can identify in the periphery at day 1, nor in day 5. But at day 3, we get about 3% of cells that are coming from the graft itself and that we can track and find in the periphery. Of course, I want to know what these cell types are, so I phenotype them further. I'm showing you on the left here, there's virtually no dendritic cells. But about 90% of them are actually neutrophils, and another 5-6% are classical monocytes, those inflammatory monocytes that I mentioned to you earlier. So we were interested in also looking at an earlier time point to see, what are the events that's leading up to this? And so, interesting thing about these classical monocytes, both recipient and donor, they're not in higher proportion at day 3. But the cells that are there actually have increased expression of these 2 receptors, CCR2 and Fc gamma receptor 1. Now, CCR2 is really interesting because it facilitates bone marrow egress, which is to say it allows monocytes to traffic from their origin in the bone marrow to sites of inflammation in the periphery. And so that's really fascinating to us, right? Because what we can imagine is maybe we can target CCR2 to then suppress monocyte inflammation and prolong allograft survival. And so current ongoing studies are focused on investigating whether this upregulation of CCR2 is important or is critical for the early immune activation that can lead to acute rejection. And so stepping back, sort of our 3-part scheme then is to use this high-dimensional characterization to be able to establish predictive biomarkers that could capture rejection episodes in advance, and also maybe be able to selectively target cells that are responding to alloantigen rather than suppressing the total immune response. And so with that, I will leave with my acknowledgments, especially thankful for my lab and Division of Abdominal Transplant and Department of Surgery, and I'll open up for questions.
Excellent talk, James. Any questions from the audience?
Really great talk. And fascinating model. So I have a question. In the case of cancers, oftentimes in tumors, you see these so-called myeloid-derived suppressor cells. And they actually have the opposite effect in terms of getting the immune system to ignore the tumor.
Mhm.
And so I'm wondering if you have compared your data sets with the MDSC data set to see whether or not there are some cytokines that you can take from the tumor
Yeah.
situation and apply it to the case of tissue tolerance.
Yeah, thank you for that question. I'll just, in the short, very transiently, I've looked at that. There's just so much to explore in this model. Haven't got to that. But what I know about myeloid-derived suppressor cells is that it's just a combination of multiple different sort of cell types. What I'd be interested in is sort of wondering if you can achieve that same granularity and sort of what are the actual cell types there. And I would bet that these sort of PD-L1 positive neutrophils would show up in that case. But I haven't, explored much beyond that.
I just have thank you. Hi, that was a beautiful presentation and an excellent talk. I just have a question about when you said you measure proteins. How do you do that? Is that like by gene expression or what specifically?
Yeah. So that's a good question because I didn't get into the specifics of it. But essentially, all of these cell types, they're expressing protein both on the surface as well as intracellularly. And so what we use are just antibodies that can bind to these proteins. And these antibodies are conjugated to these metals, sort of lanthanide metals. And so we can then sort of measure actually the metal expression using sort of a mass spec based approach, which is the mass cytometry that I mentioned there. So the increase in that particular metal that associates with that antibody corresponds to how much of that protein is there.
Yeah, James, I think that was an excellent talk. It's a really exciting study and very well presented. It's interesting, these CCR2 monocytes come up in a lot of different aspects depending on what you're researching. It's almost like they tend to be a guilty until proven innocent type cell, and a lot of it probably has to do with the state of the bone marrow when they egress. But what are your kind of thoughts on narrowing down specific phenotypes of which ones you want to target?
Yeah. So one of the sort of functions that I mentioned is that the myeloid cells will come in, leave the bone marrow, go to sites of inflammation, and sort of sustain the inflammation. How it does that, I have not characterized yet, but sort of what we think is that, or what we know is that they do sustain sort of tissue resident cells, such as, the dendritic cells and macrophages that I mentioned to you earlier. So what I think potentially is, you get constant sort of presentation of donor antigen until the donor graft is gone, right? And so that's sort of my broad, pitch of what I think is going on there. Thank you.
All right, so our next speaker is Heather Talbott. She will be presenting on inhibiting yes-associated protein prevents scarring and promotes regeneration in a large animal model of the wound repair.
Thank you so much. Okay. Good afternoon, everyone. My name, again, is Heather Talbott. I'm an MD PhD student in the Longacre Lab in the plastic surgery division. And I'm really grateful for the opportunity to present our work at this year's Holman Day. So our lab is broadly very interested in the issue of fibrosis, which can be considered a conserved response to tissue injury that occurs throughout the body and involves the replacement of functional normal tissue with non-functional, dense, connective fibrotic tissue. And I think this is a really kind of astonishing statistic that collectively fibroses are estimated to cause almost half of all deaths in the industrialized world, 45%. So this is obviously something with a really large clinical burden. Now, skin scarring is just one example of an acute fibrotic process, which affects hundreds of millions of people every year as I'm sure all of you as surgeons are well aware, and can cause really devastating consequences, as you can see here, that include not only visual disfigurement, but also physical discomfort, and in the most severe cases, mobility and growth restriction, such as when contractures occur across joints. Tissue mechanics and skin tension are two factors that are really well known to contribute to scarring, with increased tension across wounds associated with increased scarring. And this phenomenon can actually be targeted physically to minimize scarring. Surgeons have sort of been aware of this, manipulated this for over 100 years by classically incising along Langer's lines to naturally minimize wound tension. We've also more recently shown that this can be leveraged via the use of tension offloading wound dressings, which have clinically been shown to reduce scarring. We also, though in this current study, wanted to see whether we could instead reduce scarring through targeted molecular interventions rather than the use of something like a physical dressing. So this schematic depicts the canonical mechanotransduction pathway, which is the molecular signaling cascade by which cells sense and communicate changes in their mechanical environment. And we actually identified an existing FDA-approved drug, verteporfin, which blocks the very last step of this pathway at the bottom, at the level of the final transcriptional effector, the transcription factor Yes-associated protein, or YAP. And this drug is approved for systemic use in the treatment of macular degeneration. That's not really relevant to our application, but it's very important in that its clinical safety profile is very well established. Oops, excuse me. So in a study that we published in Science last year, we showed that blocking mechanotransduction in wounds using just a single verteporfin treatment at the time of wounding is sufficient to block activation of profibrotic fibroblasts in wounds and prevent scarring, and thereby yields complete wound regeneration in mice. And before I move on to the current study, I'll just review our results in mice very quickly. So again, following just a single verteporfin treatment in mouse wounds, we see regeneration both grossly. On the left, you can note the dramatic hair regrowth that is seen in verteporfin-treated wounds, and also histologically on the right, where we see evidence of regeneration of functional hair follicles and glands, which is not typically seen in scars. Furthermore, using an image processing pipeline that we developed in our lab to quantitatively assess extracellular matrix, or ECM, ultrastructure, we also saw restoration of unwounded skin like ECM, as you can see by the verteporfin wound cluster in blue overlapping with the unwounded skin cluster in green. And also consistent with regeneration occurring at the tissue ultrastructural level, we saw that verteporfin-treated wounds on the right had comparable mechanical properties to unwounded skin, including being as strong as skin, whereas scars are typically significantly weaker than skin. So in mice, just to recap, we see that verteporfin-treated wounds meet these three key criteria for wound regeneration. Number one, we have regrowth of hair and glands. Number two, we have return of unwounded skin like ECM structure. And number three, we have restoration of normal mechanical properties. However, there are really significant biological differences between mice and humans, and these cause many early discoveries, particularly in the wound healing and scarring space, to ultimately fail to translate to the clinic. As we sort of like and dislike to say in our lab, a lot of cancer has been cured in mice. And because of this, it's really important to validate those mouse findings in more human-like large animal models prior to ultimate clinical translation. So we decided to study verteporfin's effect in the gold standard, most human-like large animal model of scarring, which is the red Duroc pig. We made hexagonal wounds in 3 separate adult pigs. We locally injected either verteporfin or saline, PBS, at the time of wounding as a control, and then we closed those wounds primarily. Now, as you can see on the left, the wounds are closed under very high tension, which makes this a particularly rigorous model of scarring. And at 16 weeks on the very right, you can see we were really excited to find that verteporfin-treated wounds grossly had less scarring than control wounds. Histologically, we also see decreased scarring in verteporfin-treated wounds with early regenerating hair follicles shown on the bottom left, and sort of hinting at a molecular mechanism, we see decreased activation and expression of both YAP, that final effector of mechanotransduction I mentioned, and DPP4, which is a marker of fibrotic fibroblasts in verteporfin-treated wounds. When we performed this ECM analysis I mentioned before, we saw that verteporfin-treated wounds at 16 weeks had an intermediate ECM ultrastructure between that of unwounded skin and scars, suggesting that partial regeneration had already occurred by that point at the ultrastructural level. And mechanically consistent with this, verteporfin-treated wounds were more elastic and more strong than scar tissue, and instead were mechanically very similar to unwounded skin. And on the right, you can see we did this longitudinal cutometer analysis, and this showed that verteporfin-treated wounds actually regained elasticity over time in the later weeks of the study, suggesting that we had active pro-regenerative remodeling occurring later on towards 16 weeks. Important for safety of our application, we also saw very minimal systemic spread of verteporfin with our, again, local one-time treatment. So levels of verteporfin in the blood were basically negligible after day 0, and even at day 0, the maximum levels we saw in the blood were much lower than that, which is already approved and known to be very safe for systemic use of this drug. There were also no systemic effects noted in any of the organs we observed by a trained histopathologist, which overall indicates a really good safety profile consistent with what we would expect. We also performed single-cell RNA-seq to characterize cells in these wounds, and we identified a number of fibroblast clusters. 2 I want to focus on, though. One that was enriched in verteporfin-treated wounds and virtually absent in scarring wounds, which is the pink cluster shown on the bottom panels. This cluster had regenerative transcriptional features, and one cluster that was enriched in control wounds, the blue cluster, which had hallmarks of fibrosis and mechanical activation. By computationally analyzing RNA dynamics, we identified differentiation trajectories that actually led from the pro-regenerative cluster 1 to the pro-fibrotic cluster 4. So given this and the relative mechanical activation seen in cluster 4, we hypothesized that it could be mechanics driving that transition between fibroblast states. And by FACS isolating pig fibroblasts from each of these clusters and applying physical tension to them in vitro using this unique culture system shown on the bottom left, we found that mechanical forces alone were sufficient to drive the transition from the regenerative to the profibrotic fibroblast identity. And verteporfin not only blocked that transition from happening, but actually reverted some cluster 4 fibroblasts back into that more pro-regenerative cluster 1 phenotype, highlighting a mechanism for verteporfin to possibly reduce porcine scarring. Finally, we also treated wounds in a human skin xenograft model with verteporfin. We found that it significantly reduced scarring, as you can see, both grossly and histologically. And verteporfin treatment in these xenograft wounds yielded more regenerative ECM shown on the left, less collagen, increased markers of vascular and skin appendage regeneration in the middle panels, and similar shifts in those pro-regenerative and pro-fibrotic fibroblast clusters to that which we had seen in pigs, which overall suggests verteporfin may have similar pro-regenerative mechanisms in human wound repair. So in conclusion, just to sum up, we found that a single treatment with verteporfin at the time of wounding significantly reduced scarring and induced regeneration in a red Duroc pig model of skin scarring. Using single-cell RNA-seq, we identified porcine fibroblast subpopulations that were perturbed with verteporfin treatment, which might prevent the transition from a pro-regenerative to a pro-fibrotic fibroblast phenotype. And finally, we saw similar anti-scarring effects with verteporfin in a human skin xenograft model. So collectively, these results are really promising for translation of verteporfin to human anti-scarring applications, which is sort of what we're looking at next. I'd like to thank my lab mates, the Hague APIs, our funding sources, and I'm happy to take any questions. Thanks.
Thank you very much. Are there any questions?
That's a fantastic presentation. I really enjoyed it. I'm curious, and you mentioned that in your last sentence. The next part is a human trial. So clearly, you guys have thought about this. I'm curious, how are you guys going to set this up, and how are you really going to translate this to human conditions?
Definitely. I think we've thought about a couple of different trial designs, and that's still sort of in the works and in early development. I think the next obvious steps are organizing a trial and getting into meetings with the FDA to start talking about the approval process for this application. Something that we are really interested in, partly because of the surgical expertise of the PIs in our lab, and partly just because of the burden of this, is pediatric scarring scarring applications, things like cleft lip, where you have scarring causing not only the issues that we expect to see in adults, but also a much higher burden of things like growth restriction, speech issues. So that's something that I think we're interested in looking into. The benefit of that, there are some unique benefits to pursuing that regulatory and approval pathway. There are also some unique challenges, obviously, to doing trials in pediatric patients. So I think we're also considering sort of more traditional, trial designs in adults with things like scar revision surgeries. But that's something that we're kind of actively planning out right now. Yeah.
I have a question more about the populations of fibroblasts.
Sure.
It seems like they're very there's a lot of plasticity, right?
Mhm.
So I'm wondering, you give a single dose and then you seem to see this transition to different fibroblast phenotypes. Are they how stable are those phenotypes? And if
Yeah.
you wait and look again, or if you re-injure the skin, what happens?
Yeah, that is a really great and interesting question that I think brings in a lot of different interesting sort of biological questions. So in terms of re-injuring the skin, that's not something we have looked at. And I think that also brings in the question of, it's known that cell populations, I think mostly epithelial populations have been looked at, but we haven't thought about this in fibroblasts, have some sort of memory of injury. So that would be another interesting thing to look at, whether verteporfin might induce any sort of, positive effects on subsequent injury. We've also definitely thought about and are kind of actively in the process of looking into the timing of that drug delivery, because like you said, there's a lot of plasticity occurring between these populations. We don't know how exactly that happens. We've done some longitudinal studies of these cells. Actually, in mice, we have a separate study where we've looked at sort of molecular changes over the course of not only that initial healing period, but also the remodeling period out to about a month. And we do see that verteporfin seems to induce some sustained changes in fibroblast populations, at least out to postoperative day 30. And that's kind of consistent with what we sort of know about the remodeling period being very important to dictating scarring outcomes, but not super well understood in terms of the cell dynamics. So yeah, I think the short answer is we're kind of actively looking into that. It's a really interesting question, and I think will be interesting to look at in pigs, sort of as we've done in mice. Yeah.
One more question about two models. First, as you mentioned about pediatrics, have you thought of applying your technology in kids with RDEB, for example, epidermolysis bullosa, and their complications, not only wound scarring but also esophageal strictures? And as a liver transplant surgeon, you have a lot of fibrosis in the liver. Have you looked at that as well?
Definitely. We have not explicitly looked at those. Thank you for that question, because I think that touches on the much broader interest of our lab. And I personally am focused on scarring. There are a lot of people in our lab who are looking at, lung fibrosis, intestinal fibrosis, a lot of different organs. So we haven't yet looked at verteporfin in those applications, but I think we would really like to. As far as, we can tell from the existing literature, this sort of mechanical activation of fibroblasts to a profibrotic state doesn't seem to be unique to the skin. That does seem to happen in other organs and other fibrotic processes like cancer. So I think that would be interesting to look at. In terms of something like EB, that I think also would be interesting to look at, and we haven't. There, obviously, the sort of underlying defect is one with the epidermis, but we also know that there is, that leads to a lot of issues with the underlying tissue being exposed, and B, there's a lot of crosstalk between the epidermis and the underlying fibroblasts. So we haven't explicitly looked at that, but I think that would be really interesting too, as well.
If there's time for one more question. Thanks so much. The results is really exciting. I was wondering if there's plans in the work to study this in a radiated model, because it would be very exciting to apply it in a radiated field.
That's a great question. I don't know that we have done those experiments yet, but we other groups within our lab and in our building, the WAN group I'm thinking of, do a lot of work with radiation-induced fibrosis, and I think that would be of a lot of interest to look at, and something that we could definitely plan to do. Yeah.
Sorry, last thing, Heather. I've heard this talk before. It's a really, I mean, it's a ton of work, and it's really nicely put together. This is, I think, that's the part where you get to have a little fun. I think as surgeons, no matter where you're trained, it's a consistent message that we don't want tension ever. And so, I don't think we often think about mechanotransduction as part of that message. And so, what I want to ask is really just, for you to speculate here. Is mechanical transduction the whole picture here? Do you think addressing that is enough?
That's a great question. So my just, total instinct is that whether or not, I certainly don't think it's the entire picture. I think there are a lot of, obviously, as we touched on, different cell types that are involved in fibrosis. It's not purely restricted to fibroblasts, and within fibroblasts, it's likely not entirely restricted to this one mechanism. That said, it does seem to have, a disproportionate effect on the outcomes that we see. So I think one reason that could be that I personally think targeting fibroblasts is a really good angle is that these are, while they're interacting with a lot of other cell types, while you could make the argument that, inflammation is what initially kicks it off, or that the underlying tissue is what's driving it, these are the cells that are ultimately making that fibrotic ECM, organizing it into a kind of stiff state that prevents the regrowth of those appendages that causes a lot of the burden that we see. Whether mechanotransduction is all, I think possibly not, but again, it does seem to be very effective. I think an angle sort of orthogonal to your question a little bit is also the question of different pathways of mechanotransduction. So I only covered one. I don't want to spoil any future talks, but I think you might be hearing about one in a couple talks. But there are different ways by which cells communicate those that may be partially redundant, partially not. So I think possibly, targeting those together could be a really promising approach. I don't think we want to ignore the other angles, but it definitely seems like this is one that has a lot of promise. So,
excellent. Next up, we have Mahil Rao. I'm sorry if I pronounced that wrong. With a talk entitled "Single Cell CyTOF Profiling of Pediatric Immune Responses to Organ Transplantation Demonstrates that Allograft Type Determines Post-Transplant Immune Makeup."
Good afternoon, ladies and gentlemen. I'm Mahil Rao. I'm actually one of the pediatric ICU physicians at Packard and a postdoctoral fellow in Sherry Cram's lab in the Division of Abdominal Transplant Surgery. Like you heard from my colleague, James Harden, I study the events of that lead to cellular rejection in pediatric solid organ transplant recipients. And as most of you know, solid organ transplant can be a life-saving treatment for children with a variety of congenital and acquired conditions. We here are home to one of the biggest pediatric transplant programs in the country, having done about 70 in the year 2021 and almost 1,800 since the year 1988. And while most transplant recipients do really well, one of the toughest things to deal with is this issue of allograft rejection. It refers to immune-mediated damage of the allograft and therefore resulting dysfunction. It occurs in about a quarter of patients in the first year after transplant. Certain organs are certainly more prone to rejection than others, and damage is induced either directly by T cells or via antibodies that are directed against donor-specific antigens. It can be either clinical or subclinical, and can be either acute or chronic, depending on the speed at which this damage occurs. Unfortunately, our understanding of the events that lead up to the development of rejection is very poorly understood, and this is the knowledge gap that we're looking to address with this study. We're primarily focused on acute rejection with patients who have received heart, kidney, or liver allografts. We hypothesized that there were distinct changes that occur in immune composition of the peripheral blood that precede the development of rejection, and that understanding these changes, characterizing and understanding the populations that are involved, will facilitate the development of novel approaches to both detection and treatment of rejection. To better understand the events that lead up to rejection, we constructed detailed immune profiles from peripheral blood in the immediate pre-rejection period. We made use of samples that had been collected as part of a different study, the CyTOF6 study. In the CTOF study, peripheral blood was collected from children at regular intervals, pediatric transplant patients, regardless of their allograft status. So we were able to go retrospectively and look at those blood samples which had been collected within 30 days of a biopsy-proven episode of rejection. And for comparison, we used blood samples from individuals who had stable graft function from 12 months before and after the time of collection. Like James mentioned, we used mass cytometry, except in human cells, to measure the abundance of 32 different populations in the peripheral blood, as we've defined in this gating scheme. All of the major lineages are represented with particular depth of the CD4 and CD8 lineages, and we collectively refer to this relative abundance of populations as the immune profile of an individual. We used linear discriminant analysis, or LDA, to understand the relationship between the different profiles of patients that we saw. And LDA assigns a set of coordinates to each sample based on its similarity to other samples. Profiles that are more similar to each other are closer on this two-dimensional plot. Each dot represents the profile of a single blood sample from an individual, and they're color-coded by the allograft that was received down below. So the thing that we were surprised by was the heart samples clustered separately from intestine samples, clustered separately from kidney samples, and clustered separately from liver samples. And this actually had nothing to do with whether we were dealing with a stable or a rejecting patient. It was only based on the type of allograft that the patient received. And if we look at the types of cells that contributed to the differences between these profiles, we note that heart patients are actually enriched in subpopulations of natural killer cells, the CD56 bright, CD16 negative cells, while certain CD8 populations are enriched in liver recipients. So these data again suggest that the immune response of the human differs based on the type of the allograft that is received, and we are currently exploring the basis for why this occurs. But when we correct for the differences of the influence in allograft on immune profile, we made a couple of other interesting observations. The x-axis on this plot shows how different population abundance is based on graft health. Those populations on the right of the plot have the greatest difference in abundance between stable and rejecting populations. So specifically, I'm focusing on the TOT cells, the CD8 central memory cells, the CD8 naive cells, and then the overall CD8 T cells that are not labeled by any of our other terminal gates. When we compare the abundance of these populations between patients who have stable graft function compared to those who are experiencing rejection, across all of the different allograft types that we observed higher abundance of CD8 naive and CD8 central memory cells in rejecting patients, and lower abundance of TOT cells in these same patients. So for the purposes of this talk, I'm going to focus primarily on the TOT cells because they are ones that we have looked at previously in the lab and are of particular interest to us. So what are TOT cells? Well, they're a subpopulation of T cells that was first identified actually in 2016 by our group as being more abundant in liver transplant recipients that had achieved a state of operational tolerance. In other words, these are individuals who don't develop rejection even if they aren't receiving exogenous immunosuppression. This suggests that these TOT cells may actually function as sort of an endogenous immunosuppressive mediator of immune function in these patients. And so we wanted to go back and look at what exactly these TOT cells, what their functional aspects could be. And so we did some basic immune profiling of TOT cells, comparing them to both regulatory T cell populations and effector T cell populations. Interestingly, the TOT cells have expression patterns that are intermediate levels of FOXP3 and CD25, which many of you know are markers of immune suppressor function, but they don't actually have high levels of T cell activation as manifested by CD40 ligand. So to summarize, I've shown you data that's indicating that the peripheral blood immune profile of an individual is largely dependent on the allograft that's received and not necessarily on the graft type. But when we take these differences of allograft type into account, we actually see three populations that emerge as differentially expressed between patients with stable graft function and those experiencing rejection. In particular, the CD8 central memory and the CD8 naive cells, as well as the TOT cells. And these TOT cells represent a phenotype that is, they have a phenotype that is somewhere between that of an effector T cell population and that of a regulatory T cell population. So in the broader picture, we believe that the TOT cells, CD8 central memory and CD8 naive, may actually be potential biomarkers of rejection that we can assess non-invasively or minimally invasively. And by understanding the function of the TOT cells, they may represent a targetable population for the treatment and or prevention of rejection. And so with that, I'd like to stop, and I'd like to thank the Division of Abdominal Transplant Surgery for the opportunity to pursue this work, as well as our collaborators from the Department of Pathology who did a lot of the biomedical informatics work. And then thanks to the chairman of pediatrics and my division chief for giving me the time and the resources to do so. This work's been funded by several different sources listed on the right. And this is our wonderful lab who you've seen already with James's presentation, without whom we couldn't do any of this.
That was a great talk. Do we have any questions?
I assume, because I'm the invited speaker, that I'm expected to comment on most of this. So please say if someone else wants to speak. These presentations have been fantastic, so I want to congratulate you to some really nice work. I'm curious, as a clinician, obviously rejection is something we deal with all the time. It's really having biomarkers that are early in the process is essential, because basically we're always behind, right? We measure very crude things like LFTs, and that's kind of behind the ball game, and this plays towards getting things really early in the process. And you mentioned you were gonna, this allows you for targets. This allows you for further investigation. So where are you in that process to actually use this? I mean, I would assume that the measurement part would be fairly non-invasive to examine in a cohort. Have you guys, is that the next step, or?
Yeah, so that's certainly, because with this study, we actually just measured single time point in a bunch of individuals. And what we think would be helpful is to actually take the same individual over time, which we do have access to the samples from the CTOT study, and look at how TOT levels fluctuate. And is there fluctuation, or is there a drop in TOT levels that's associated with the development of rejection? Because that could be a key feature of developing a new assay to detect rejection. In terms of function, we actually know very little about TOT cells, but we, as I mentioned, they have some regulatory features and some effector features. And so maybe they represent something that's intermediate between the two. And can we use cytokines to push them, to push the cells in one direction or the other? And can that be used as sort of a more targeted way to suppress the immune system?
I assume those kind of studies you would first do in an animal model, or even more basic, right? Is that part of what you're doing?
Yes. So the issue that we're a little bit limited by is that we've identified TOTs in humans. We are looking for them in animals. And so if we're able to identify them in animals, then that represents a nice model that we can nudge their function one way or another.
I think the data with that shows differences according to the organ transplant is really interesting and surprising, at least to me. I'm not sure how to interpret that, but I'm wondering if you think it has to do perhaps with the fact that individuals have some organ-specific disease for the transplant, or the allograft itself is changing the immune profile post-transplant, or you could look early on at the time of transplantation. I don't know what the kind of wanted you to speculate on what you think about that.
Yeah, I think that there are three buckets in which we could explain some of the differences in the allograft. One, as you mentioned, is this a pre-transplant? Do these differences exist prior to transplant as a result of the underlying disease process? And for sure, in the heart failure literature, there is evidence that heart failure leads to massive changes in the immune response. The thing that may argue against a pre-existing condition is all of these kids have theoretically regained normal graft function, and we're at various points outside of the transplant window. And so I would expect that if there were changes in immune function, they would have reverted. Not necessarily true, but it certainly would be what I would expect. I think another bucket is immunosuppression. Could this be the effect of different forms of immunosuppression? Truth be told, we have a relatively limited number of immunosuppressive agents, and they are definitely applied at different levels and targeted at different levels depending on the type of organ that's received, especially some of the induction therapies. But I think that it'd be a little bit hard for me to attribute this entirely to immunosuppression, since we do have such a variety of regimens that are used across centers, and we're still seeing this kind of consistent segregation. And then lastly, of course, I think is what would probably be potentially the most interesting, which is that the allograft itself determines the immune response, which has profound implications for the treatment of rejection.
Really, really nice data. The clustering seemed pretty convincing. I sort of have two questions around that. One is, whenever you're going to set up peripheral blood immunophenotyping on a new population, you start to see worrisome things, like if you took my blood in the morning and at night, suddenly it's very different. Do you have any sense with this panel that you have consistency, within the same donor? I don't think you can test that on kids, but even healthy controls. And the second is the TOT cells. There are algorithms, even though we only know about them in humans, or have identified them in humans, that can sort of place them on some sort of lineage path. Do we know where they came from? Do we know what cells sort of preceded them?
So let me answer the second question first, because I think that might be a little bit easier to answer. So we know very little about TOT cells, and I think this is the second time that we've seen it pop up in a anti-rejection paradigm. And so one of the things that we're really planning to do, is figure out what do they express, and then do that kind of lineage analysis that you're talking about to help figure out where do they come from and what are they looking like. The first question about the human heterogeneity is one that I think that I certainly underappreciated, and I think you bring up a good point. To be honest, am not sure how much of a factor that's going to play, how much of a role that's going to play. And I think with large cohorts, hopefully we'll be able to at least reduce some of that variability, but I do think it is a significant concern.
Great, thanks so much.
Okay, so our next speaker is Michelle Griffin, and she will present on adipocytes, the forgotten cell in skin fibrosis, exploring the mechanism of fat-driven skin fibrosis.
Good afternoon. My name is Michelle. I'm a postdoctoral fellow in Dr. Longacre's lab and a plastic surgical registrar from London. So skin scarring occurs following any skin injury following the dermis. And humans develop hundreds of millions of new scars every year, which can cause physical disfigurement, discomfort, and immobility. However, no treatment to prevent or treat skin scars. Understanding how scars form is of utmost importance. Now, traditionally, wound healing has been classified into 4 stages. It starts with plugging of the wound to stop the bleeding, followed by infiltration of the immune cells in the inflammatory phase, and then the bulk of the work is done by those fibroblasts that come in and lay down collagen to cause, unfortunately, fibrosis. But as you can see, under all these layers is a yellow layer, and that's full of adipocytes. And traditionally, it's not thought that these play any role in wound healing. But fat and fibrosis do have a close and likely complex relationship. And many fibrotic diseases, like scleroderma, a systemic skin scarring condition, involves dysregulation of fat. As you can see in this histology image, in scleroderma, where we lose fat, we gain fibrotic tissue. So this question to me, could these adipocytes, these fat cells, go into fibroblasts within the wound environment and cause this skin scarring. So to answer this question, we first create skin wounds in the back of the mouse and evaluated if these adipocytes do become fibroblasts. But to rigorously test this, I had to develop a genetic lineage tracing model. So in these mice, mature adipocytes and their derivatives, including adipocyte-derived fibroblasts, express GFP. So they're the green cells. And all the other cells, including the adipocyte non-derived, express RFP, and they're red. And we did see that 10% of those wound fibroblasts in the wound were derived from the adipocytes around day 14, both by immunohistochemistry and flow cytometry. But the most interesting thing to me was that there was more than one type of adipocyte-derived fibroblasts. Now, the majority were in the deep layer, but there were some in the middle layer. That showed to me that we're not just looking for one thing. So I moved to a different transgenic model. Here I used what we call at Stanford the rainbow mouse. And we can use flow cytometry to separately isolate fibroblasts on the basis of this rainbow color. So we can interrogate this heterogeneity of the adipocyte-derived fibroblasts, which are either now red, blue, or orange, from the other fibroblasts, which are green. I then performed single-cell RNA sequencing from each of these rainbow colors, and we found 5 transcriptionally distinct fibroblast clusters. Now, while most of them had both adipocyte-derived and non-adipocyte-derived, interestingly, one cluster 3, which is this blue one in the middle there, had almost exclusively all of them adipocyte-derived fibroblasts. And compared to all the other fibroblast clusters, which express mechanical activation genes such as YAP, which you've heard about from Heather, piezo-1 and 2, which are my new mechanical sensitive ion channels, cluster 3, the exclusively adipocyte-derived fibro cluster, didn't have any mechanical genes. And this is the term now I'm going to call mechanical naive. And they had a description just like an adipocyte. So this question to me, maybe these adipocytes may transition to fibroblasts, but via an intermediate state. And could this all be driven by mechanics? As surgeons, we know mechanics is everything. So could this transition be driven by mechanics? So to confirm our hypothesis that the adipocyte to fibroblast transition is due to mechanics, we first developed an in vitro cell culture system with a colleague called Kellen Chen in the Gertner lab. This allows us to stretch cells and monitor their behavior. And we found that mechanical stretching alone caused mouse and human adipocytes to lose their adipocyte genes and gain typical fibroblast gene expression genes. Furthermore, though, when we applied mechanical inhibitors, both piezo-1, piezo-2, YAP, and FAK, we stopped this transition with just the mechanical inhibitor. But the most interesting thing was that piezo-1 and 2 were far more superior than YAP and FAK. And this highlighted to me, maybe this piezo signaling functions at a much earlier stage at the adipocyte activation process. So given these in vitro results, I further questioned whether applying a piezo-1 and 2 inhibitor could act on these bad fibroblasts and convert them back to the good things, the adipocytes I want in my wound to prevent skin scarring. So to answer this question, we went back to the rainbow mouse, we created the same wounds, but at the time of wounding, we administered piezo-1 and piezo-2 inhibitor, and we monitored the wounds for 14 days. And excitingly, both piezo-1 and piezo-2 inhibition caused grossly reduced scarring and increased fat accumulation around the wounds, with significantly reduced scar thickness and increased hair follicles on histology. And the regeneration was far more superior with the piezo-1 inhibition. Given my promising results with the piezo-1 inhibition preventing scarring, we wondered whether it could also rescue existing scars, one thing that's never been done in the literature to date. So we wounded the mice, and this time waited in post-op day 30, at which point wounds were engaged in scar remodeling. Then he administered either piezo-1 inhibitor or PBS, and allowed them to go for a further 30 days. We were extremely excited to find that both piezo-1 inhibitor administered to existing scars at post-op day 60 led to significant regeneration by post-op 60, with dramatic hair growth both grossly and histologically, compared to the control wounds, as you can see at the bottom there, which were base fibrotic scars. These results are not only translationally promising, but only mechanistically exciting, as it suggests to me that the adipocyte fibroblast transition is not only in acute wounds, but also in the long-term wounds, which as surgeons, this is what we see every day. So in conclusion, I hope I've shown that adipocytes do become fibroblasts in wounds and contribute to scar formation. We've shown that this adipocyte to fibroblast transition is mechanically driven. And for the future, given the massive role of fat and fibrosis in many organs, such as the liver and the intestine, we're now investigating the role of these adipocyte-derived fibroblasts and to see if mechanical inhibition via piezo may decrease the fibrosis. I'd like to thank all the supervisors of Dr. Michael Longacre and Dr. Wan, all the members of the Longacre and Wan laboratory and Dr. Gertner's laboratory, my co-first authors, Heather Talbott and Nicholas Guardino, they're sitting in the audience. Happy to take any questions.
Thank you very much. Any questions from the audience? Dr.
Again,
Ledner?
this is
Dr. Ledner.
it's wonderful. It's really interesting. And your very last sentence was actually going to be my question. I'm going to expand a little bit on that as somebody who's very interested in cirrhosis and kind of building also on Laura's previous comment. So you have shown, and I assume others too, those cells can become fibroblasts. Can they become liver cells? And have you seen these cells per se, like in the liver tissue at all? Do we know that?
Interesting. I work with a colleague. We found in the intestine there's mechanical sensitive genes that are popping up in these fibrosis genes. Today I haven't looked at liver fibrosis, but I think considering I've seen it now in 3 organs, I think the fibroblasts that we're seeing that are causing fibrosis are the ones that have gone there and they've taken these mechanical genes and unfortunately caused down the collagen fibrosis. I'm sure it's the same subset that we will see in liver. I think we're hunting for the same fibroblast, something in our lab that we know very strongly and passionately, and I think that is true. And so by preventing it early, especially with the liver, that the fat is going to move in there, and we've seen it clinically, we see it. So I think it's only a matter of time.
It's a very naive question. I mean, this is all based on skin and the mechanics related to it. The scarring in the liver is not necessarily mechanical, it's more chemical often, and through invasion of population of fat within the cells. Does it require the mechanical stimulation for this? Do we know?
So something we're taught as soon as we walk into Dr. Longacre's lab. Every time we get scar tissue, it's due to stiffness. So the whatever the consequence, tension is playing a role. Because as surgeons we think about it in the skin, doesn't mean the tension isn't there in the liver. So I think yes, there is other things playing a part, but I think definitely mechanotransduction is playing a vital role.
And I wouldn't disagree with you because cirrhotic liver is like it is super hard, whereas healthy liver is very soft. Yeah, it's really cool.
Other questions? Yes, please.
The results are really exciting, particularly for me, because it shed some light perhaps into the mechanism and of 2 conditions that we currently don't have a cure for. One is lipedema and the other is lymphedema, which is part of the manifestation of these diseases is hyperproliferation of these adipocytes, which leads to significant fibrosis and leads to their disease progression. So I'm really interested to see future results on this research, and because if we can block that pathway, perhaps we can reverse the disease process.
Yeah, thank you for your question. It's so funny that you say hypertrophy of fat, because in the human adipocyte gels, which I only showed you the mouse gels, one of the most interesting findings to me was that the adipocytes actually expand and become, before they turn towards the fibroblasts, they become bigger and hypertrophic. So that's one of the things I'm trying to work on, is if I can identify those ones, then maybe I can even prevent it at a much earlier stage, not at the fibrosis level. So that's thank you for that information. Thank you.
one more question, and again, that might be very naive, but we're talking about scarring is something bad all the time. But what actually, how you can apply this in a normal wound healing? We know also that obesity is correlated with a actually poor wound healing and complications, and we know that obesity is associated with a pro-inflammatory state within the fat, right, adipocytes. So how do you translate your findings with more clinical application like that?
Yeah, so thank you for the question. So there's another pig study actually we have in the lab, bleomycin-induced fibrosis. The reason I'm bringing that up is we're seeing the same sort of genes and this fat becoming fibroblast in that model, but inflammation is playing a role. So I think mechanics is a strong driver and definitely can prevent, but there is other things that in such things as obesity, such things as liver fibrosis, where inflammation plays a dominant role. How can we supersede? Is mechanics alone going to be there enough? I think that's a massive question, and I think we definitely need to understand more about inflammation. So yeah, we're looking at obesity as because it's the primary thing of fat, but there may be other things that we can involve with, such as inflammation.
Thanks, Michelle. I don't think we can really understate how exciting these findings are, and that we're getting a sneak peek at them. I think that the story you've taken from zero to now is something we all kind of hope for as scientists. So, congratulations. And next up is Carlos Ayala, going to talk about appendiceal mucinous neoplasms and pseudomyxoma peritonei, defined by distinct cellular states and a goblet cell identity.
Hi, everyone. Thanks, the Holman committee, the moderators, and our division for allowing us to present our research. Let's see. I have nothing to disclose. Pseudomyxoma peritonei is a disease state that follows perforation of the appendix in the presence of a mucinous neoplasm. Historically, these tumors have been very challenging to study due to their gelatinous nature and the low cellularity. Current guidelines call for cytoreductive surgery and HIPEC for surgically fit patients. Commonly, mitomycin C is used as a perfusit for HIPEC. So we set out, and our objective was to characterize the tumor microenvironment of these tumors. In order to conduct our study, we collected normal tumor pair tissue from 5 patients with mucinous appendiceal neoplasms without perforation. We've called this cohort AMN, and the pathology was lemon. In addition, we collected tumor and ascites from 9 patients with mucinous neoplasm of the appendix, but with perforation and peritoneal dissemination. This cohort we have called PMP, and the pathology is mucinous adenocarcinoma or MACA and lemon. The collected tumor was minced and then enzymatically dissociated to generate single-cell suspensions that were used to create single-cell libraries that were analyzed by in-house developed pipelines. So the first thing we did was to combine all of these libraries to generate UMAP plots that you can see here on the left. And using different lineage markers, we identified different lineages. And the most important thing, and this is what you would expect or hope to find in the tumor microenvironment of any type of cancer that you're studying. But if you look at the right, this is where you start seeing the interesting aspects of the disease. So if you look at the different patients, or if you look at different tumor metastases within the same patient, you can see that you can start seeing differences in the proportion of these lineages, which probably play a role in the biology for each individual patient, and also the response they're probably going to have to any therapy that you give them. However, for today's talks, we'll only be focusing on the epithelial lineage here. So the next thing we did was to extract these epithelial cells here, and we basically interrogated them by using different gastrointestinal lineage markers. And you can see that if you look at the left panel on the heat map, we identify pretty much all of the different GI lineages that you would hope to find, for example, in colon and appendix as a neighbor. And again, if you now start looking again at each individual patient, and also at the different metastatic lesions within a single patient, when you look at these lineages, you can see that pretty much the dominant phenotype here is a goblet cell identity. Especially when you look at the PMP cohort and you look at tissues that typically do not harbor any epithelium, like the omentum, you can see that it is pretty much enriched with goblet cells, or cells with a goblet cell identity. So next, we've identified this cell lineage as a culprit behind the disease. The next question we wanted to ask is, so we have all these epithelial cells, so how can we get further insight into how this disease progress? And what's the relationship between AMN and PMP epithelial cells? So in order to evaluate this question, we basically conducted trajectory analysis using Monocle, and I'll walk you through the busy slide. So basically, you're going to start at a root, and from that root, everything's going to start branching, and then all of these epithelial cells will essentially start going on a differentiation path along the trajectory. And what you basically see is that you start in these state 1 and state 2, which are basically progenitor cells that go on and develop and sort of differentiate into a goblet cells phenotype. And eventually you make it to state 5, where you pretty much have a metastatic profile. When you look at the same trajectory by looking at the different cohorts and how they're contributing, you can see that everything seems to start here at the AMN, and then you continue to progress where you pretty much at the end are left with a PMP cohort, which suggests that these tumors are progressing from an AMN phenotype all the way to the PMP phenotype. And then if you then, again, do the similar breakup where you take each of these states and you evaluate the proportion of all of these different states in patients or their different metastatic lesions, what you see on the PMP cohort is that basically that's where it gets dominated by the state 5, where there's metastases. Again, which you would expect to find because these AMNs are restricted to the appendix, and most of them have not perforated, so they have probably have not reached the same sort of state once the perforation happens and everything disseminates and invades the abdominal cavity. So now that we have found all these different states, the next question was, so what are the different signaling or cellular activation pathways that are happening to get to state 5? And can we find any new novel pathways that we can target pharmacologically in the future? So we did a GSVA analysis of all of these different cell states. And if you basically look at state 4 and state 5, which is dominated by PMP, and this is the last stage of this disease, you can see that now you have novel pathways that are lighting up, like PI3K or KRAS. And importantly, when you look at state 5, which by gene expression flags as a metastasis, you can see that there's high activation of the epithelium-mesenchymal transition, which supports that basically these are true metastases. So we have found these epithelial cells. We found the culprit of the disease, which has been pretty much very hard to do historically because of just how challenging these tumors are to work with. So the next question that we wanted to ask is, we usually use mitomycin when we perform surgery. So what exactly is mitomycin doing, and is it targeting what we wanted to target? So to answer this question, what we basically did, again, we used some of the same tumors that we collected, we enzymatically dissociated them, we generated single cell suspensions, and then we either froze those cells at time 0, or we mock treated them with saline or treated them with mitomycin. And the first question that we set out to address is mitomycin having a cytotoxic effect in a dose-dependent way, and whether temperature is important. And when you look at the 37 degrees, if you look by using a luminescent assay on these single cell suspensions, you can see that at 37 degrees there's definitely some cytotoxicity, a higher dose. And then if you do the same experiment at 42 degrees, which is typically the temperature that we conduct HIPEC in the OR with hyperthermia, you can see that, again, there's a dose-dependent effect, but there's also a temperature-dependent effect. So again, what we're doing in the operating room at a higher temperature does have relevance in terms of the cytotoxicity that it's going to generate. So Now that we know that mitomycin C is having a cytotoxic effect, the next question we wanted to see is, or ask, is whether it is actually targeting the cells that we want. So for these, since all of these are single cell suspensions, we created libraries and analyzed them. And you can see that when we looked at each cell lineage, you can see on the top that once we treat with mitomycin, and I should say this was even at 37 degrees, not at 42, there's definitely a cytotoxic effect on these mucinous epithelial cells, and there's also a really profound effect on the lymphocytes. While the mesothelial cells, and it is because this is momentum that we're using on this specific patient, is pretty much untouched. So the effect of mitomycin is specific to the cell lineages that it will impact, but it is at least definitely having the effect that we want on the cells that we want, which has never been shown. So with that, in conclusion, we basically shown that AMN and PMP lesions have mucinous epithelial cells with a goblet cell signature. We did not show this today, but we've shown that these mucinous epithelial cells do also behave like goblet cells. And we've shown it just because when we do mass spectrometry analysis of the ascites, all the products of these cells are actually found in the ascites. And they contribute to the formation of the ascites. That mitomycin C is cytotoxic in a dose and temperature dependent way. And that mitomycin C treatment results in the reduction of these mucinous epithelial cells and lymphocytes while sparing the mesothelial cells. So with that, thanks to the G Lab, the department, and the Surgical Oncology Division for all the help and support. Thanks.
Really nice study, Carlos. Any questions?
So this is wonderful. Again, really interesting work. If you fast forward 10 years, what do you hope as a clinician, as future clinician, you and a lot of other people will have developed that you can actually apply?
That's definitely the next step. So one of the challenges with this type of disease is if you don't qualify for mitomycin, or like if you're not a candidate for HIPEC, then your options for any type of treatment is very limited. And not only limited, but it doesn't work well. So it will be systemic chemotherapy, which is definitely not as good as HIPEC. So I think looking forward, hopefully we can also try novel targets. The problem with this disease is that I think systemic therapy without cytoreduction is not going to be good, because this disease, the cells coat in mucin, so you cannot access the cells without actually doing the surgery to the bulk. So any type of therapy in the future, at least personally, I would say has to be intra-abdominal, whether it's through a catheter that you liquefy, like try to liquefy that ascites if you're not going to be like a candidate for the bulking, with novel targets will be an option. But even if you can palliate by doing some cytoreduction with any of these novel targets, will probably be better than nothing. But it's a challenging disease.
Thank you so much for the talk. It was wonderful. I was curious about the cell of origin for these tumors. So in intestinal adenocarcinoma, it's thought to be an APC mutation in LGR5 intestinal stem cells. Do you think that this would be a secretory progenitor, maybe an HOH1 positive cell that might undergo some kind of oncogenic mutation leading to this mucinous phenotype?
Yeah, I do believe it is more of a secretory progenitor. When you look at this progenitor, some of the transcription factors are actually more secretory than just like pure sort of intestinal. And I actually, I've done a single cell analysis on a patient with appendiceal adenocarcinoma, and the profile is totally different. It is more similar to what you see in colorectal adenocarcinoma. And this phenotype is like, is basically purely a goblet cell identity. The interesting thing is, like, when a pathology sees these tumors, they cannot call them as goblet cells. Otherwise, they would have beaten us to this. But they do not only have a goblet cell phenotype in terms of the identity and the transcription factor, but they also behave like goblet cells, because they're basically dumping the secretory products into the ascites. So it is an interesting, like biologically, it's very interesting how this tumor behaves.
Carlos, this is excellent. I mean, it's probably, I would imagine, the most comprehensive study in this type of tumor that exists, and I can't imagine how you did all the single cell analysis with so much mucin. I mean, that, the reality is these droplets in the abdomen are mostly mucin a lot of the times, and so just a testament to what you were able to accomplish here, and how few people, really want to deal with these tumors. I think what I'm wondering is a little more abstract, but it sort of gets at one of those questions where how do we link what we see clinically to what we're seeing scientifically? And I think a good example is the signet ring cell. And so, somebody told me in fellowship, go look up a signet ring cell and tell me how to classify it with, modern technology. And it was impossible. And so what do you think it represents? Where do you think it stands in this sort of spectrum?
So yeah, unfortunately, I was hoping I could get my hands on a signet cell through when I was collecting, but I don't think we were ever lucky. I think the closest we can get is if we get a gastric, and just like extrapolate how the gastric signet looks compared to like to ours. And but yeah, it is challenging. I don't have a good answer for the signet. At least for these tumors, I think if we can combine like some of these new like novel targets with HIPEC, or even if we can like administer like intra-abdominally with something that like can liquefy the ascites, which there are, like people use and acetylcysteine and bromelain to sort of liquefy some of these, but it is hard. Like it is very hard to work with the mucin. Yeah.
Really great talk and very interesting results. Goblet cells are actually one of the key cell types that are infected by the COVID virus, in spite of the fact that their goblet cells are secreting tons of mucus. So I'm wondering if you've seen whether or not ACE2 is expressed in these tumor cells. Perhaps there might be a way moving forward using oncolytic virus derived from COVID.
Completely possible. What I would say is the lung has goblet cells, and they are very similar. Like some of the similar pathways. So I didn't go into it, but EGFR and MAP kinase, which flag on our pathway activations, not on this one, but on different analysis, are two of the most important cascades driving goblet cell differentiation. The problem with our tumors is that probably half or more of these patients have a KRAS mutation. So even though it's one of the best cascades, it's probably not the best one to target, but it is there are similarities between the lung goblet cells and the goblet cells in the GI tract.
Thanks a lot, Carlos.
Yeah.
Great job.
All right, so our next speaker is Wang Xinghong, and she will present on neoadjuvant intratumoral immunotherapy with TLR9 activation and anti-OX40 antibody eradicates metastatic cancer.
Good afternoon, everyone. My name is Juan. I am a general surgery resident here at Stanford. I'm honored to have the opportunity to present at Holman, and I'm excited to talk to you about my research on neoadjuvant intratumoral immunotherapy in some preclinical models of metastatic cancer. My mentor serves on the advisory board of a couple of different companies. Myself and the other individuals who worked on this project have no disclosures to report. This research was supported by the 2 NIH grants listed above. So in order for my research to be possible, it was preceded by the acute observations and accomplishments of many brilliant scientists and physicians who came before me. And I would just like to take a brief moment to pay homage to their accomplishments. The first description of cancer and cancer surgery comes to us from the ancient Egyptians. They describe a removal of breast cancer using a fire drill, or what we would call modern surgery cautery. In 1863, Rudolf Virchow identified leukocytes in cancerous tissue and thus made the first connection between inflammation and cancer. In 1891, William Cooley, who we regard as the father of modern cancer immunotherapy, attempted to harness the immune system for treating cancer. He noticed that a number of his cancer patients went into spontaneous remission after developing erysipelas, and he tried to inject mixtures of live and inactivated streptococcus and serratia bacteria into patients' tumors. Unsurprisingly, this did not quite catch on at the time. In 1909, Paul Ehrlich proposes the immune surveillance hypothesis, which is the thought that the host immune system is capable of preventing neoplastic cells from developing into tumors. In 1949, the first chemotherapy drug is approved by the FDA. In 1996, blockade of CTLA-4 was found to lead to spontaneous tumor rejections in mice, which subsequently led to, in 2011, the approval of ipilimumab, which is a CTLA-4 inhibitor, in the use of unresectable or metastatic melanoma. And then in 2021, immunotherapy was advanced to the neoadjuvant arena when the FDA approved a PD-1 inhibitor for high-risk early-stage triple-negative breast cancer. And more recently, in 2022, the FDA approved another checkpoint inhibitor for resectable non-small cell lung cancer for neoadjuvant use. I think it's very clear why the FDA and why physicians are interested in expanding the use of immunotherapy into the neoadjuvant arena. There are a number of reasons why neoadjuvant therapy is beneficial. First of all, it allows for early determination of therapeutic efficacy. It permits for the assessment of pathological response. It could potentially reduce overall tumor burden and minimize the extent of surgery that's required. It can improve systemic disease control. And with neoadjuvant immunotherapy in particular, the intact tumor can serve as an antigenic reservoir for T-cell priming. We too became interested in investigating immunotherapy in the neoadjuvant setting. So for the purposes of the rest of my presentation, the immunotherapy regimen that I'll be talking about is a combination of CpG and stimulatory anti-OX40 antibody. CpG is a single-stranded DNA fragment that contains immune-stimulating unmethylated CG sequence motifs. It stimulates immune cells by engaging TLR9, and OX40 is a stimulatory receptor from the TNF family. And the two have been shown to act synergistically to promote an anti-tumor immune response. And we had published on this particular combination in 2018. So in order to investigate the use of neoadjuvant immunotherapy, I started with a simulated model of both local and systemic disease. The cell line I used was CT26, which is a murine colorectal carcinoma cell line. To simulate local disease, I inoculated the tumor cell line into the flank of wild-type BCL mice and bulb C mice. And then to simulate systemic disease, I inoculated the tumors through the tail vein to achieve pulmonary metastases. The mice were treated with 3 neoadjuvant intratumoral, meaning that we injected the neoadjuvant therapy directly into the tumor in the cohorts of mice once the primary tumors had reached a standard size. We then waited 4 days after neoadjuvant treatment and then resected the primary tumor. We tracked local recurrence, we tracked systemic disease, and we looked at overall survival. As you can see, CT26 is not a super aggressive tumor. Most of the mice that were treated with either vehicle or CPG alone or anti-OX40 alone or combination did not have tumor recurrence. However, looking at systemic burden, this is where we saw the biggest difference. Mice that were treated with vehicle, essentially no treatment, just resection, mice that were treated with no resection but just immunotherapy, and mice that were treated with neoadjuvant immunotherapy followed by resection were compared over time. The systemic disease burden was measured using IVUS in this graph, and we found that over time, mice that had neoadjuvant immunotherapy followed by resection had much better systemic disease control. More strikingly over here, you can see the lungs of mice that were treated with vehicle versus neoadjuvant immunotherapy. As you can see, the lungs on the left side are much more clear. Finally, looking at survival, unsurprisingly, with better systemic disease control, we found that mice that were treated with neoadjuvant immunotherapy followed by resection had much better overall survival. However, we wanted to use an orthotopic, spontaneously metastatic disease model and not one that simulated both local and systemic disease. So we next looked at the 4T1, which is a murine mammary carcinoma cell line model. This is a very aggressive tumor cell line, which I'm sure people who do cancer research are very familiar with. It spontaneously metastasizes, and it is pretty resistant to various different types of therapeutic maneuvers. Again, we inoculated the tumor into mice, but this time into the mammary fat pads. We treated the mice with neoadjuvant injections, either of immunotherapy, vehicle, etc. And then we waited again 4 days after the last treatment and resected the primary tumor. We looked at local recurrence, we looked at systemic disease, and again, we looked at survival. For local recurrence, the mice that underwent vehicle and resection initially, of course, had no local disease after the resection, but over time, a lot of the mice had recurrence. Systemically, you can see that mice that were treated with just vehicle had a lot of disease in their liver and lungs, which are the organs that are shown here, whereas the mice that were treated with neoadjuvant immunotherapy had a much lower burden of disease. And again, we found that the mice that were treated with neoadjuvant immunotherapy followed by resection had much better survival compared to the immunotherapy alone versus the vehicle and resection. In fact, we actually had no survivors that were treated with just vehicle and resection or just immunotherapy. So we had essentially very similar findings across both preclinical tumor types. The one other thing that we found interesting was that survivors from the prior experiment were re-challenged with re-injections of the same tumor type versus a new tumor type, and these are long-term survivors. And we found that 5 days after tumor inoculation with the same cell type that they've been exposed to, tumor cell type on this side, and then a new tumor cell type they had previously not been exposed to, they start developing a tumor on the side where they received injection of the new tumor cell type. And this is even more apparent 10 days after tumor inoculation, whereas they're able to still reject the same cell type that they'd previously been cured of and have been exposed to. This allowed us to conclude that their tumor memory, their immunologic memory was tumor specific. We had hypothesized that T cells play a vital role in this therapeutic response. To confirm that, we again treated the mice with neoadjuvant immunotherapy followed by resection. In this experiment, all the mice received the exact same therapeutic treatment. They all received intratumoral neoadjuvant immunotherapy followed by resection. The only difference was that one cohort has CD4 T cell depletion with depleting antibodies. Another cohort has CD8 T cell depletion, and a third cohort had both CD4 and T cell types depleted. And then for the control group, we had no T cell depletion. So even though the mice had received, these are all the same mice, received the same tumor injections, even though they had all received the same treatment, the mice that had T cell depletion had recurrence, whereas the mice that had no T cell depletion had the lowest local tumor recurrence. And you can see in systemic disease burden, and this is just IVUS bioluminescence tracking the systemic disease burden. This is no depletion. You can see that one mouse had a burden of disease was N of 10, so this is a 5 representation. Whereas in mice that had both CD4 and 8 T cell depletion, the mice very quickly had recurrence, had this systemic disease, and no survivors. So on the survival plot, again, we saw that T cells play a very vital role in this reaction, or in this therapeutic efficacy. Mice that had both CD4 and CD8 T cells responded as expected to neoadjuvant immunotherapy, whereas mice that had depletion of both populations of T cells all died. So as I mentioned previously, this is a local immunotherapy maneuver, meaning that we're injecting the neoadjuvant immunotherapy directly into the tumor. So one thing we wanted to prove was that the systemic abscopal effect that we were seeing was not a fluke, that the immune cells were actually leaving the tumor microenvironment and circulating systemically to provide systemic immune protection against the tumor cells. So we had the same mice, same treatment mice, treated with neoadjuvant immunotherapy. The tumor is in the mammary fat pad. What we did was we harvested the spleen, which is a remote organ, and we separated the T cells from the spleen. We took the T cells and we incubated them with just media, with stimulating antibody, with a tumor cell type A20 that they've never been previously exposed to, and with the same cell type that they've been previously exposed to. And we found that for both 4T1 and CT26 tumor models, the mice, the T cells from the spleen had an increased immune reaction, as demonstrated by CD44 upregulation, interferon gamma, increased expression in the spleen when exposed to the tumor cell type that they were inoculated with. And we looked at other distant sites. We looked at draining lymph nodes and the lung. And again, we saw that mice that were treated with neoadjuvant immunotherapy had increased Ki67 proliferation T cells and granzyme B when they were treated with immunotherapy. So that for us illustrated that even though the therapeutic maneuver is local, that local immune response is able to spread systemically to provide abscopal systemic protection against the cancer. We also noticed through our research or experiments that some of the immune subsets in the tumor microenvironment had increased expression of PD-1. This led us to ask, what if we were to combine CpG and anti-OX40 with systemic PD-1, which PD-1 inhibitor, which is an accepted immunotherapy used on humans. And we did that. We inoculated the mice with intratumoral immunotherapy, CpG anti-OX40. We also combined that with systemic anti-PD-1. And we found that though we had a good response in the T cells with just CpG and anti-OX40 compared to vehicle, when we added anti-PD-1, we had an even more robust response from the T cells. And my apologies, this should say draining lymph nodes and lungs respectively. But again, we saw increased proliferation in T cells in those distant organs when anti-PD-1 was added to CpG and anti-OX40. We looked at systemic disease burden, at local recurrence, and at survival for these mice. And we found that when mice were treated with an addition of anti-PD-1, we had survival that was even improved on what we saw with just neoadjuvant CpG and anti-OX40, and improved systemic disease control as well. So ultimately, we concluded that local administration of neoadjuvant immunotherapy improves survival, systemic disease control, and decreases local recurrence. We found that immunologic memory in long-term survivors is tumor-specific, that disease control is T-cell dependent, and we concluded that local immunotherapy takes advantage of pre-existing T-cell immune repertoire within the tumor microenvironment, and that those T cells, once activated, are capable of inducing abscopal anti-tumor effect at distant non-treated sites, resulting in better systemic disease control. We found that the addition of anti-PD-1 mediated anti-tumor immune responses by relieving suppression of T cell and resulted in improved therapeutic efficacy. And finally, we felt that intratumoral immunotherapy, including our combination of CpG and anti-X40, is readily translatable to the clinical setting. And I would just like to thank my mentors, Dr. Ronald Levy, his wife, Dr. Shoshana Levy, both of whom have independent labs and are the mom and pop of cancer research here at Stanford, as well as Edith, who was the postdoc that I worked with, and Deborah, who was our lab manager. Their support made this project possible, and they really inducted me into the world of immunologic research. Thank you for your attention and time. I'm happy to answer any questions you might have.
Thank you, Dr. Hung. I think we're behind. This was an excellent talk and very interesting research, but I think the questions will have to come during the break.
Sure.
Thank you.
So next up, we have decoding and modulation of spiking activity of the sciatic nerve in an awake and moving rodent by Katharina Fischer.
My name is Katharina. I'm a postdoc in Dr. Gertner's lab, and today I'm going to talk to you a little bit about decoding and modulation of spiking activity in the sciatic nerve in an awake and moving rodent. So conventional prostheses currently don't interface with neural activity directly. They either use body motion or muscle activity as a proxy, and therefore they are difficult to use. The patients using them tire quickly, they have limited function, and they do not provide any sensory feedback. The end goal of prostheses is to make up for the lost limb, so therefore two key facts are necessary. First of all, the prostheses should be able to record neural activity in order to infer the intended movement, in order to recapitulate all the degrees of freedom that a healthy human hand would have. And secondly, the prostheses needs to be able to stimulate the neurons in order to provide sensory feedback so that the person using the prostheses actually knows what's going on down there. So that's why we sought to develop a device which combines both of these key things necessary for a prosthesis and interfaces with the neurons directly. In order to develop this device, it needs to cause very low damage to the neurons. It has to have high fidelity and has to be stable over a long period of time. In the past, multiple of these peripheral nerve interfaces have been developed, but currently there is a big trade-off between selectivity and invasiveness. So for example, the Utah-slanted electrode array, as to be seen here on the right side of the slide, it's able to selectively record single units in a healthy human ulnar nerve, but due to the mechanical mismatch between the electrodes and the actual axons, it causes extensive scarring, foreign body response, and Wallerian degeneration, which renders the device non-functional after a couple of months. Yep. So that's why we came up with the hypothesis that by matching the size and the compliance of our electrodes to those of the native axons in the peripheral nerve, we'll be able to minimize the neural injury caused through the device and also the foreign body response. And here you can see in the schematic to the left side, the electrodes of the Utah-slanted electrode array, and on the far right side, the size scale of our device, the electrodes each being 4 microns wide and 10 microns thick. Here you can see how our actual device looks like. In the left picture, you see the white spots. Those are our electrodes, each on an individual strung. And the schematic on the right side, you can see how the electrodes are arranged within our device. So because this device is ultra flexible, it can't be inserted into the nerve by itself. So that's why we had to invent a technique. We call it the insertion shuttle. And in the schematic on the upper right side, you can see it. It's made out of a microneedle, which is threaded through a hole at the end of the device. And in the picture down below, you can see the whole setup. Here you can see the microneedle and the device next to it. And here's a close-up view where you can see the microneedle threaded through a hole at the end of the device. And now with this, we're able to insert the needle through the sciatic nerve of the mouse. Here you can see the needle perpendicular to the nerve. Pull the needle through, subsequently pulling the device through. You can then remove the needle and have the device inside the nerve. Here you can see a 2-photon image with the green being the axons of the sciatic nerve and blue being our device. And this demonstrates that we are actually in the size scale of native axons. What we then wanted to do is we wanted to see if we could induce movement through stimulation. So currently our device has an unprecedented high density of electrodes in devices this size. We currently have 16 electrodes in our device. And I hope the videos work. In the red video, you can see that through stimulation, we are able to induce movement down to a single toe level. And also very exciting, in the orange movie here, you can see that we can induce a whole paw grasp through stimulation of one electrode. If you then look at the color-coded schematic on the right side, you can see that the 3 electrodes colored orange, those are the ones through stimulation inducing the paw grasp. And the 2 electrodes that are colored red are those inducing the 4th toe movement. So this is very exciting because through this we can create a topographical map of the functionality of the nerve. The next thing, what we wanted to see is if we actually get neural signal through our device. And for that, we placed the mouse on a treadmill, had it run on there for a period of time, and we got some signal. So each of these lines represent one electrode, and you can see multiple spikes. With these being interesting, but also we got a lot of noise. So to more precisely look at if the spikes are actually neural activity, we then used a computational method called spike sorting, and we were able to identify 8 putative units within the nerve, meaning 8 groups of neurons that actually we get signal from. And now if we look at this, we're able to, in the future, hopefully, decode the movement, decode what neurons are active in which phase of the movement, and then modulate that movement very specifically. So that's one of the things we're going to look into in the future. Also, the next thing is we want to upscale the device. We want to increase the channel counts, induce more electrodes, place more electrodes within the nerve, and translate that into a larger animal model. And last but not least, we want to confirm that our device actually minimizes the foreign body response using histopathology. So thank you all for listening, and I'm happy to take any questions.
Thank you so much. Really exciting application. Unfortunately, we are still a little bit behind, so we'll hold on questions and welcome the next speaker.
And our next speaker is Peter Diptala, treating lymphedema with propeller lymphatic tissue flap combined with an fibrillar collagen scaffolds. Thank you.
Okay, thanks so much. Lymphedema is a very difficult problem to treat and involves a multidisciplinary aspect of care. And from the surgical side of things, we can perform debulking procedures such as liposuction to address the soft tissue fibrofatty excess, and also physiologic procedures which address the excess fluid seen in lymphedema. And these are lymphaticovenous anastomosis and the lymph node transplantations, or VLNTs and LVAs. But these procedures do not address the non-functional lymphatic channels that occur throughout the length of the lymphodematous limb. So in order to find adjunctive therapies to help with that, this rat hind limb model was very instrumental. And our senior author of this particular paper was involved in creating this model, and it involves excising the popliteal lymph nodes, the inguinal lymph nodes, as well as administering 20 grays of radiation. And in 2 weeks, the rats are developing a lymphodematous limb. And this model was very useful in developing a novel technology called BioBridge, which is a nanofibrillar collagen scaffold, which you can see on electron microscopy, consists of these highly aligned collagen fibrils that the ultimate structure creates these nanopattern channels that work to help treat lymphedema, initially through capillary action to initiate the interstitial flow of the lymph fluid, but also serving as a scaffold for the cell migration, attachment, and alignment, and thus it does support lymphangiogenesis. And BioBridge is very easy to place. It's subcutaneously placed where superficial lymphatic vessels run naturally, but you go from an area of intact lymphatics distally, bridge over an area of diseased fibrosis, and towards a healthy lymph nodal basin proximally, and this can be done with essentially a suture passer device. And we used the rat model to look at BioBridge in our early preclinical studies, and the results were actually quite nice. BioBridge was useful in not only treating lymphedema, but also preventing it. And so we've subsequently been incorporating this collagen scaffold into our treatment algorithms here at Stanford. And we've even been using it in the more difficult late stage 2 and 3 lymphedema cases where it's notoriously difficult to establish long-term normalization of lymph volumes. But here in our more recent study with a triple therapy approach, we're seeing normalization of lymph volumes out to almost 2 years, which is quite fabulous. And the issue is physiologic surgery has a very high technical demand. And if you look on the far right corner, that is a background that's, each square is about 1 millimeter in size. So these vessels are sub 1 millimeter. You're using super microsurgical technique, special microscope, special instruments, and special sutures, 11 or 12 sutures, which you have to get special from Japan. And to make this a little bit more feasible and available to patients, we thought if there's a way to introduce a physiologic procedure that could be a little bit more easier to perform. So we went to this idea or this concept of the propeller flap, and it is a tool that we use in reconstructive surgery. And in this case is an example of a lower extremity reconstruction where you have a distal defect, a flap of tissue that's based on an eccentrically located perforator, so not in the center. And when you rotate that flap 180 degrees, you're able to transfer that proximal healthy tissue distally to cover the wound, and you close the secondary donor site. So we thought to apply this to treating lymphedema, combining this with BioBridge and testing this out in the rat hind limb lymphedema model. So we started out with 24 rats. We performed volumetric analysis prior to developing lymphedema, and we separated them into 3 groups: a control, a flap alone group, and a flap with the collagen scaffold group. And at 4 months, we performed volumetric analysis and ICG lymphangiography. And at the termination of the study, we performed histology to see if there were any differences between the groups. And for the surgical technique, after lymphedema is established, we move to the contralateral healthy unaffected groin. So this is the right groin in these specimens. We elevate this healthy lymphatic tissue flap based on the superficial epigastric artery, rotate it 180 degrees, and that gets it across the midline to the contralateral left affected groin. And in our group B, the flap alone group, we stop there, and that's the treatment. And in group C, we also add in 4 strands of this BioBridge collagen scaffold in subcutaneous fashion. And so what did we find? Well, we were able to get 15 rats to successfully develop lymphedema, and about 80% is pretty good for this model. And we divided them randomly into the 3 groups, 5 in each group. In terms of the volumetric analysis, you can see on the far right, our control group, group A, the lymph volumes were essentially the same at the 1 month and 4 month time frame, but our treatment groups saw a drastic decrease in lymph volumes. So the lymphedema was improved in those groups. We also looked at the number of lymphatic collectors, and these are the actual channels that you see lighting up on ICG lymphangiography. Okay, so the more channels, the better, the more robust your response. And so in the control group, group A, we saw about 1, whereas our treatment group B, we saw an average of 2, and then in the group that had the flat plus the BioBridge scaffolds, we saw an average of 3 collectors. So more collectors and a more robust lymphatic recovery. And these are representative images of the 3 groups, A, B, and C, taken at the same point in time after ICG is administered. And you can see that group C has a very robust lymphatic network. We also looked at ICG transfer time, and that's just the speed at which the lymph is able to flow from the paw to cross the midline. And in the disease state of lymphedema, it's, you expect it to be quite slow. There's stasis, the lymph doesn't move anywhere. And that's exactly what we saw. So group A had, 330 seconds to get to the midline, whereas our treatment groups were less than half that time. We also looked at something called the lymphatic pattern index. This is something described in the literature to sort of quantify the morphology of the lymphatics. So in a disease state, you see very disorganized, tortuous lymphatics that just don't go anywhere. That's lymphedema. But in a healthy state, you see more linear, efficient, direct lymphatic vessels. And so in group A, the lymphatics were, a score of 1, so more tortuous, as what we would expect in a lymphodematous limb. But our treatment groups tended to be more convex or linear after receiving these surgical treatments. And from a histology standpoint, at our conclusion of the case, these are representative slides, H&E stain. The top photos represent the control group, and you can see there is a lot of edema, especially in the subcutis. You even have edema in the subfascial level and going into the muscle, whereas our flat group, group B, that edema is drastically decreased. And lastly, in our flat plus collagen scaffold group, that edema is further decreased, but you're also seeing, so on that lower left corner, kind of looks like the Jupiter red spot on the upper left-hand corner. That's the collagen scaffold. That's the BioBridge that's still present. And around this collagen scaffold, we're beginning to see new vessels being formed. And on the higher magnification on the lower right, those are new vessels with endothelial cells, and they're filled with fluid with particles that are very consistent with lymph. So these are new lymphatics that we're actually seeing around these scaffolds. And so based on this study, we can see that this propeller lymph node flap plus BioBridge collagen scaffold can help to reduce lymphedema in this rat model, and we're looking forward to a larger sample size before beginning to apply this to treatment in the human patient. Thank you so much.
Thank you very much. I think we're short on time, so I will pass the microphone to Dr. Holman.
Thank you so much, Dr. Kirchner and Dr. DeLito. I want to congratulate all the trainees on their outstanding presentations today. Really phenomenal work. I mean, we saw such amazing accomplishments, findings that are happening by our trainees that I think are going to impact and shape the future of care in many different areas. So congratulations. And I want to thank the mentors who really take on the responsibility of guiding our trainees through the research process and mentorship. So let's give a round of applause to everybody.